Interventional angiography is an X-ray examination in which the blood vessel is opacified using iodinated contrast medium. So it is opacification of the vessel using iodinated contrast medium. Contrast medium is low osmolar to decrease the complications. And angiography is divided into arteriography and venography according to the vessels opacified. Arteriography, so we record. Okay. I'll repeat the slides. Angiography is an X-ray examination which the blood vessels is opacified using iodinated contrast medium. The contrast medium is low osmolar to decrease the complications. It is divided into arteriography and venography. Arteriography is an examination in which the arteries are opacified using contrast medium. The procedure or the technique is called Sildinger, and the usual access site is the femoral artery or the femoral vein, according to whether it is arteriography or venography. We can also access the arterial system from the brachial artery. Indications for arteriography is for diagnosis of vascular diseases such as vascular occlusive disease, aneurysm, AV fistula, and AV malformation. Diagnosis or localization of vascular tumors such as insulinoma or parathyroid adenoma. Preoperative definition of vascular anatomy, for example, preceding organ transplant for the donor and for the host, and for the recipient, local tumor resection and revascularization, for diagnosis and treatment of vascular complications of diseases, trauma or surgery, and performance of vascular interventional procedures such as angioplasty, stenting, etc. These few slides will summarize the indications. So this is in the role of angiography in the diagnosis of vascular disease. This is a coronary angiography, and the catheter is inserted in the coronary artery. You notice here the stenosis, the high-grade stenosis of the vessel. And this is a post-interventional, post-angioplasty run of contrast, and you notice here that the vessel has returned to its normal diameter. So this is role in the diagnosis of vascular disease and in the assessment of the treatment. This is angiography showing AV fistula. These are the femoral vessels. This is the common femoral artery dividing the superficial and deep. And this is the femoral vein. You notice here the presence of abundant, tortuous, large vessels that are taking up contrast and early opacification of the femoral vein. So this is an AV fistula, and this is post-embolization, post-coil embolization of the fistula. You notice the diminished flow within the fistula, and you don't have any more opacification of the venous side. This is an angiography of the cerebral arteries, and you see here a saccular dilatation of the vessel. This is aneurysm, MCA aneurysm, visualized in this angiography. This is the role of angiography in the detection of vascular tumors that sometimes are occult by other radiological investigations. This is a case of parathyroid adenoma, which is very nicely depicted as a blush of contrast because of its avid vascularity in this angiography of the neck. And this is the role of angiography in the assessment of the renal transplant in a patient with who wishes to donate the kidney, a donor assessment for the branches of the renal artery. As we mentioned, it has a role in patients with trauma and surgery. This is a case of fracture involving the proximal tibia, and you see here the signs of vessel injury. In this angiography, you notice the severe narrowing of the vessel. This is also a case of fracture of the femur, and this patient is hemodynamically unstable, and because of this you have an active bleeding point and expanding hematoma in the thigh. You have an active bleeding point. This angiography shows this extraluminal flush of contrast. And this is image after embolization of the bleeding point. We mentioned that angiography, the technique is called Seldinger technique. Now, what's Seldinger technique? Step-by-step Seldinger technique involves the insertion of a catheter into the vessel. How to bring a catheter, which is an silicone tube or a plastic tube, sorry. How to bring it inside the lumen of an artery. This is by Seldinger technique. First, we puncture the vessel while using a needle. Then, placement of guide wire through the needle and advancement of the guide wire. After the guide wire is in the vessel, the needle is withdrawn. Then the catheter will be threaded on the guide wire to reach the vessel of interest, and then the guide wire can then be removed. Only the catheter will remain inside the artery. So this is Seldinger technique. Advantages of Seldinger is easy and quick to perform, can be used for different catheters of any length. Small gauge needles are used, allowing entry into the area without cut down, with minimal trauma to the surrounding tissues. A disadvantage, however, is blockage of the artery by thrombosis secondary to the entrance of the artery, and difficulty in stopping bleeding because you don't have large open field to stop the bleeding, difficulty in stopping the bleeding that may require urgent surgical intervention. Now, DSA is digital subtraction angiography. This is the standard angiography nowadays. It obtains images of the opacified vessels only with subtraction of the background, giving advantage of using higher resolution images, smaller doses of contrast medium. What do you mean by digital subtraction? If you give contrast and opacify the vessel, and then you obtain the X-ray, this is what angiography is about. You opacify the vessels with iodinated contrast medium, and then you obtain an X-ray of the vessels. What you will have an overlap of the bones and soft tissue markings on your vessels. In DSA, you will have a pre-contrast, pre-injection image, and after injection, you will subtract the two images digitally, and what you get is only visualization of the arteries. So you see here the faint background of bones no longer visible. This will give you higher resolution images and better detection of lesions, and also allows the use of less contrast medium. What about venography? Contrast venography is routinely used for the evaluation of the upper limb veins, as it enables imaging of the central veins in the arm in neutral and abducted position, allowing for functional evaluation. However, its use is less in assessment of the lower limb veins because ultrasound is widely used for assessment of lower limb veins with good accuracy. In venography, you need large volume of contrast medium injected in a vein in the arm or in the hand. The contrast is then forced to the deep venous system of the upper limb by means of tourniquet. We don't want it to dissipate in the superficial system. It is forced into the venous system by means of tourniquet, allowing visualization of the deep system, because this is what it's all about, is evaluation of the deep venous system of the upper limb. Then thrombi will be seen as filling defects in the opacified veins. As you can see here, you notice these filling defects appearing as lucencies in the opacified vein. Or you can see stenosis or occlusion in the central vein. As we said, venography in the lower limb is seldom performed because ultrasound is well suited to the assessment of lower limb veins. We will shift now to another modality that will allow vascular imaging, that is MR angiography. MR angiography is a very useful non-invasive technique for both arteries and veins, so it is MR arteriography and MR venography. It relies on special sequences that depend on the signal obtained from flowing blood. Okay, so it does not have to use contrast necessarily. We can rely on flow-sensitive sequences to obtain images, or an optional use of contrast agent, that's gadolinium, to increase the resolution and especially for imaging of the peripheral veins. So it can be done with contrast, it can be done without contrast. We routinely assess the arterial and venous system of the brain, MRA and MRV of the brain without contrast. The vessels that can be imaged using MR angiography are the aorta and its branches, portal vein, carotid artery, peripheral vascular disease, renal and mesenteric artery stenosis. Aneurysms and vascular malformations can also be detected in the intracranial circulation and elsewhere. These are images, MRA images of the whole body. Notice it can depict the arteries brilliantly in the cerebral circulation, the carotids in the neck, the vessels in the upper limb, the heart, aorta, renal arteries, and the iliacs, and also peripheral assessment. And these are images showing you the areas. This is the aortic arch branches, pulmonary arteries. These are the renal arteries and the peripheral arteries, the iliacs. MR angiography can be used to visualize any vessel, but commonly and most commonly the intracranial vessels, the aorta and the renal arteries. Notice this example of patient with multiple stenoses involving both subclavian arteries, nicely depicted on MRA. And this is an image, MRV image, showing the normal superior sagittal sinus and lateral sinuses. Notice here, this is MR angiography of a stenotic segment of the internal carotid artery shortly distal to the bifurcation. These two are MRA images, and this is the DSA image, and notice the nice proximity of the images and the near accuracy of the images as compared to the gold standard, which is DSA. This is MRA depicting multiple aneurysms in both iliac arteries and lower limb vessels, aortic aneurysm. This is a magnified image of MRA showing nicely aortic aneurysm. And this is MRA showing us peripheral arterial disease with atherosclerosis and lack of flow in the right iliac down to the superficial femoral artery, and the narrowing seen on the left. So you can see MRA is useful in the assessment of peripheral arterial disease in patients who have atherosclerosis. Now we move on the role of ultrasound of the arterial system, starting by ultrasound of the arterial system. We mean by ultrasound of the arterial system is the combined use of ultrasound and Doppler in the assessment of the arteries. There are multiple arteries that can be assessed using Doppler. Carotid arteries and peripheral vessels. Commonly, the primary imaging modality will be Doppler. The location and size of any atheromatous plaques in the carotid and the severity of luminal narrowing can be determined. With color imaging, we can assess whether there is stenosis or occlusion. Then we can overlay our spectral trace. By spectral, we mean we have waveform analysis to analyze flow velocity waveforms, which can give us further information regarding the degree of stenosis. Imaging of the iliac vessels may be difficult due to overlying bowel gas. Evaluation of the abdominal aorta is successful and can easily be performed. Really, ultrasound is one of the useful screening methods in the assessment of aortic aneurysm. By Doppler, we mean we start by putting our ultrasound, we call grayscale image. So we assess visually the vessel. This is the common carotid dividing into internal and external carotid, and you notice here the presence of this plaque. So we can assess the plaque and we can try to quantify the degree of stenosis, first of all, starting by only the grayscale. Then we can overlay the color and we try to assess the lumen that is stenosed and the degree of stenosis. This is the vessel outer diameter and this is the flow. So we can quantify again the degree of stenosis using color. Also putting on color, even if the vessel is not obvious, the area of stenosis will show as turbulence of the flow, multiple flows, aliasing. This is called aliasing, which is the presence of multiple colors within the stenotic area, indicating turbulence. Again, this is color Doppler showing areas of aliasing, suggestive of stenosis. So we know by color that we have an area of stenosis. Then we can put our spectral Doppler trace overlying it and obtain velocity waveforms. Generally speaking, velocity will increase in an area of stenosis, and by knowing the how many times it has duplicated, we can assess the degree of stenosis by knowing the velocity, the degree of velocity rise. So this is the use of arterial Doppler in the analysis of stenosis or occlusions of the arteries. What about ultrasound venography? It is useful, very useful in detection of venous thrombosis, DVT. With venous thrombosis, what we will see is an intraluminal material visible within the veins in grayscale image, in grayscale, that is ultrasound. Also, when we compress, the veins will lose their normal compressibility, because normally when we compress, the veins will be totally compressible. Thrombus-free veins should be compressible by direct pressure. Then we can put our color on, and color Doppler scan will show us whether there is lack of flow or not. This ultrasound venography is useful in the assessment of the iliac, external iliac, common femoral, popliteal veins. However, in the calf distal to the popliteal vein, the sensitivity will drop. This is an example of ultrasound venography. And just by looking at the grayscale image, we know that this is a thrombus that is seen within the gray saphenous vein. And this is a popliteal vein. And with compression, when we compress, the vein will not compress. This will indicate that this is thrombosed. We may put our color on and see that we have areas, thrombus will be shown as areas of lack of flow. So all are used, the color and the compressibility and the grayscale, in order to diagnose deep venous thrombosis. Venous Doppler is also useful not only in peripheral veins and detection of DVT, but also useful in visceral veins, such as the portal vein, in the assessment of flow, in the assessment of portal hypertension, and in the assessment of portal vein thrombosis. Now we move to the next section in our lecture, which is the interventional radiology. You have any question? أي سؤال عندكم على part of angiography before moving on to interventional radiology? Okay. إذا ماكو سؤال نكمل ويا part of interventional radiology. We start by angioplasty. We mean by interventional radiology the procedures that the radiologist will do in order to overcome a stenosis or to opacify, to perform a therapeutic action on a vessel or an organ without the need for open surgical procedure. We'll start by angioplasty. Angioplasty is a minimally invasive procedure. So it is invasive but minimally invasive procedure performed to improve blood flow in the body's arteries and veins, done with or without vascular stenting. So angioplasty, as we said, it is with or without stenting. When you have buildup of plaques that's chronically blocking the flow, Then we will traverse this area by a catheter with balloon. Opening of the balloon will dilate the area of stenosis and will restore the normal vessel diameter. And then we may put a stent or not, depending on the vessel. Sometimes the stent is needed, sometimes it is not needed. So this is angioplasty, balloon angioplasty, and this final step is the balloon is removed and the stent, expandable stent, is put. Angioplasty, the femoral artery is the access route. It is widely employed in peripheral vascular disease. It can give result as good as bypass surgery, particularly for the iliac and superficial femoral artery disease. The ideal lesions for treatment by angioplasty are short stenoses, rather than long segment stenoses or occlusions. So short stenoses are the ideal lesions to be treated by angioplasty. In renal artery stenosis, angioplasty is indicated to treat patients with poor renal function, flash pulmonary edema, or renal vascular hypertension that is resistant to medical treatment. It can be used also in mesenteric arteries to treat mesenteric ischemia and is increasingly used for carotid artery stenosis. These are the balloon systems, the catheter with the balloon that is used for angioplasty. So this is the catheter, the balloon is not inflated, it enters the vessel, then the balloon will be inflated, dilate the vessel. Another modification of angioplasty is called subintimal angioplasty. It is useful for complete occlusions. As we said, the balloon angioplasty, the routine balloon angioplasty is ideal for short stenoses. For complete occlusions of the peripheral vessels of the lower limb, and the principle is to create a new channel in the subintimal plane, rather than to recanalize the original lumen. So instead of normal angiography, which bypasses the original lumen, subintimal angioplasty will go in the subintimal plane beneath the intima, dissect the vessel, and then dilate the segment. It is more useful in long occlusions or long stenoses. Finishing with angioplasty, moving on to a second variety of interventional procedure, that is therapeutic embolization. Therapeutic embolization is occlusion of the arteries. And we may need to occlude an artery that is feeding a tumor, or occlude an artery that is actively bleeding to control bleeding. Arteries can be occluded by introducing variety of materials through catheters selectively placed in the vessel. Metal coils covered with thrombogenic filament, gelatin foam, small particles made of polyvinyl alcohol, and cyanoacrylate glues that can solidify on contact with blood, all have been used for therapeutic embolization depending on the vessel that is embolized. These techniques have been used primarily to control bleeding. Once arteriography has demonstrated the bleeding site, which is the site showing active extravasation of contrast, the offending vessel then can be embolized. Aneurysms of the intracranial artery, the aneurysm sac, is being increasingly undertaken, thus avoiding craniotomy. So this is an example of a large liver hematoma that is expanding. And this is angiography showing the active bleeding as this extravasation of contrast, this rounded extravascular collection of contrast. And this is تسمعوني يا طلاب؟
نعم دكتورة أسمعك.
تمام، إن شاء الله راح نكمل من وين ما توقفنا. بسم الله الرحمن الرحيم. And this is an image showing an aneurysm of the intracranial arteries before embolization, and this image of DSA showing the disappearance of aneurysm after embolization by coils. Therapeutic ablation. Therapeutic ablation is another interventional radiological procedure. Metastatic liver lesions and certain other primary tumors can be ablated percutaneously using a variety of physical techniques such as heating, using radiofrequency, laser or electrocautery, or freezing by cryotherapy, or injecting a noxious agent such as ethanol into the tumor. The size and location of the tumor help to determine which method may be appropriate. The treatment is performed under image guidance using ultrasound, CT, or MRI. One of the most frequently used of these techniques is thermal ablation of hepatic metastasis. So ablation is percutaneous introduction of a physical or chemical agent that will lead to injury and death of the tumor focus, physical such as heat or radiofrequency, and chemical such as ethanol. Another form of interventional radiology is vascular catheterization for infusion, transarterial chemoembolization. So it is a catheter that is inserted in a vessel, and this catheter is used for infusion of cytotoxic or radioactive agents directly into the malignant tumor to minimize systemic toxicity and to double the effect, the toxic effect on the tumor. So you see here the catheter is introduced in the closest vessel that is possible nearer to the tumor, and the cytotoxic material, mostly chemotherapeutic agent, is injected, reduce the size and the viability of the tumor. Now moving on to another form or type of interventional radiology, which is thrombolysis. Thrombolysis, arterial catheters placed for infusion of fibrinolytic agents to dissolve fresh clot from the vascular system. So this is the catheter. It is introduced through the clot, and the catheter will infuse a thrombolytic agent so that it will help lyse the clot at the site. Another form of interventional radiology is vascular stents and filters. Stents are expandable metal cylinders that can be embedded in plastic and collapsed to enable them to be inserted through the artery or vein. Then, we expand them at the site of the lesion by means of balloon. Stents are commonly used in the treatment of arterial stenosis and occlusion in coronary arteries, renal arteries, and also in peripheral arterial disease. We have also what is called EVAR, or endovascular aneurysm repair. Somewhat similar to stent, covered metal stents can be used to exclude aneurysm, either in small vessel or increasingly in the thoracic or infrarenal aorta. In EVAR, this is the aneurysm. Instead of tackling the aneurysm sac surgically with the hazard and bleeding that comes with this procedure, there is a way of putting a stent within the aneurysm, this time not for dilatation, but this aneurysm will act to exclude the aneurysmal sac from flow. So the flow will come, and instead of passing through the aneurysm sac, which on time and on exposure to systemic arterial blood pressure, this will lead to aneurysm expansion and rupture. The blood will not enter the aneurysm sac, rather it will be excluded from flow, and flow will pass through this EVAR graft, okay, and will distribute to the iliac vessels. So this is an example of aneurysm before and after EVAR. Still the sac is there, but it is not opacified and being excluded from the systemic flow. Stents can also be introduced through the femoral vein and placed across a stricture in the superior vena cava to overcome the distressing syndrome of superior vena cava obstruction, which is usually caused by malignant tumor in the mediastinum. So for symptomatic relief of this symptomatic syndrome. Another form of interventional radiology is the placement of Ivc filters. Ivc filters can be introduced percutaneously through the femoral vein. The filters will trap emboli originating in the leg or pelvic vein thrombi. They are used in patients who are at risk of pulmonary embolism that cannot be managed satisfactorily with anticoagulation or when anticoagulation is contraindicated. So the idea is to put something in the IVC that will catch thrombi and prevent them from reaching the pulmonary circulation or the renal arteries by putting filter if we can't control the DVT medically for whatever cause. There are a variety of shapes and types of IVC filters that differ. This is a morphology, and this is morphology. There are variable commercial types, and this is IVC filter trapping an embolus, preventing it from reaching upward. Another form of interventional radiology is percutaneous needle biopsy. It is a non-operative confirmation. It is used for non-operative confirmation of suspected malignancy. It can be performed under fluoroscopy, ultrasound, or CT guidance. Most intrathoracic, intra-abdominal sites can be suitable for this procedure. Now we can obtain fine needle aspiration using 20 to 22 gauge needle. Material can be obtained for cytology. So we have percutaneous biopsy and we have percutaneous fine needle aspiration cytology. The FNA needle, as we said, the small bore needle, can pass through blood vessels, vascular masses, loops of bowel, solid organs with only minimal risk of infection or bleeding. Apart from small pneumothoraces with intrathoracic biopsy, the complications are extremely rare. Instead, the percutaneous routes can be used for FNA, which means a small bore needle, 20 to 22 gauge with minimal complications, but it can be used for larger tissue samples using a larger needle, 14 to 18 gauge for soft tissue, and 10 to 13 gauge for bone. This is percutaneous needle biopsy. Larger needle requires specific approaches to avoid damage to the structures because you cannot pass such a needle through bowel or through vascular masses because it will lead to complications such as infection or hemorrhage. So this is an example of sampling a lesion in the abdomen using percutaneous needle biopsy to obtain material with this minimally invasive procedure. Now we will move on to another form of interventional radiology, which is percutaneous drainage of abscesses and collections. Various abscesses in various spaces can be accessed radiologically, sparing the patient open drainage. Specially designed drainage catheter is introduced percutaneously into abscesses or other fluid collections. The catheters vary in diameter from 6 to 14 French, depending on the nature of the fluid to be drained. The larger catheters may have double lumen to assist irrigation of the abscess cavity. Ultrasound, CT, and fluoroscopy are the usual methods that are used to follow the procedure and to help introducing the catheter. This technique is suitable for most abdominal abscesses. It is successful for liver and intraperitoneal abscesses, proven success, much less satisfactory for pancreatic abscesses, and if the abscesses are multiple or multiloculated, because then we cannot access the entire abscess cavities. Similar technique can be employed to insert a chest tube to obtain pleural effusion, to drain pleural effusion or empyema. This is an example of abdominal abscess, right iliac fossa abscess. Mostly this is after appendicitis. And this is interventional radiology using CT guidance to insert a drainage tube into this abscess, sparing the patient open drainage. Technique of interventional radiological procedure is the procedure TIPS. You are all familiar with TIPS, transjugular intrahepatic portosystemic shunt, hypertension, with complications, namely bleeding gastroesophageal varices and intractable ascites, are candidates for TIPS. There is creation of a communication between the portal and systemic venous system to lower the portal pressure. When other attempts to treat the varices, such as sclerotherapy or banding, have failed. It is done percutaneously under ultrasound guidance. An internal jugular vein is punctured. Catheter then is placed through the heart into a hepatic vein, and using a special needle introduced through the lumen of the catheter can then be passed from hepatic vein into portal vein. Once this portosystemic connection within the liver parenchyma, we introduce the needle down into the hepatic vein branch, puncturing the liver parenchyma to the nearest portal vein branch. Once this portosystemic connection has been established, it is kept with a permanent stent. So you notice that this is the pre-TIPS varices when the TIPS stent, before insertion of TIPS stent, and this is after insertion of TIPS. You notice the lack of varices because there is preferential drainage of blood through the TIPS stent and lack of visualization of the varices. Moving on to a few set of interventional procedures for the GIT, biliary system, and the urinary system. For the GIT, esophageal, duodenal, or colonic stent placement can be done. Expanding metal stents are usually placed across malignant strictures, but newer removable covered stents are increasingly used in the treatment of benign strictures. So in patient with, for example, gastric cancer with symptoms and the patient is beyond surgery, for symptomatic measure, we can produce a stent across the narrowed area. Also, other interventional GI procedure is percutaneous gastrostomy. It can be performed endoscopically by passage of endoscope perforating the stomach and out through the anterior abdominal wall, or radiologically by puncturing the stomach and putting a stent, or as a combined procedure by both transcutaneous and endoscopic routes. For the biliary tract, interventional radiology for the biliary tract, those with drainage tube is introduced endoscopically, which is the common approach. Insertion of a stent, biliary stent, endoscopic insertion. But the most common causes of common bile duct obstruction are tumors and stones. Among tumors, we have CA pancreas or cholangiocarcinoma that can occlude the distal CBD, and stones within the CBD. As for stones, if the obstruction is due to stones, then endoscopic removal of the stones and sphincterotomy of the papilla of Vater is frequently the chosen procedure. So the endoscopic retrieval or removal of a stone plus the sphincterotomy for free passage of the stone into the duodenum. And for malignant obstruction for tumor, it is by putting a stent, a permanent stent across the stricture if it was surgically non-resectable, and most of cholangiocarcinomas are advanced and surgically non-resectable. Biliary stents can be introduced also percutaneously, especially when the endoscopic route has failed. Non-operative stenting and the drainage procedure for patients in whom curative surgery is impossible, those are candidate for percutaneous drainage. Patient may live for a considerable time with biliary stents in place, particularly if the responsible tumor is slowly growing, such as cholangio. It is mostly advanced, but even with advanced tumor, it is slowly growing, so the stent can stay for a long while and spare the patient the symptoms and the pain and the jaundice. So it is very useful in the management of patients with cholangiocarcinoma. So you notice here a percutaneously inserted drainage that is going all the way, decompressing both lobes of the liver, and the terminal end of the stent is introduced then into the duodenum for drainage of bile to the duodenum. And this is an example of a percutaneously inserted catheter from the skin down into the duodenum, allowing for decompression of the biliary tree and to avoid obstructive jaundice in patients with terminal or with advanced cholangiocarcinoma. نحن إن شاء الله وصلنا إلى نهاية محاضرتنا. Interventional radiology, selected procedures has been given. Interventional radiology is very wide subject with a lot of applications. So this is only a sample of the interventional radiological procedures available. وعندكم أي سؤال؟
لا دكتور إن شاء الله.
بالتوفيق إن شاء الله.
شكرا جزيلا دكتور.
مع السلامة.